So, good afternoon, everyone, and thank you for being here this afternoon. We'll do introductions later. We'll do the housekeeping first. We're not expecting a fire alarm, so if the alarm sounds, can all present leave the building as quickly as possible by way of the nearest exit. The designated assembly point is in the public square in front of Cast, beyond the fountain and away from the civic office. And if there is anybody with mobility issues, please wait in the refuge area at the top of the stairs, where the emergency evacuation lift is located, and use the intercom situated to the left-hand side of the lift doors to call for assistance. There will be no roll call. Thank you. Mobile phones, can I ask that we've all got them switched to silent and we're not having any tunes being played during the meeting? This meeting will be audio-visually recorded and will be available to view on the Council's website and YouTube channel. And can I ask all those present to use their microphones and remember to switch them off when you've finished to ensure that we capture all the audio. And any members of the public entering the Council chamber are accepting that their images will be retained and broadcast by the Council. I don't think we have any members of the public here. If any members of the public are in attendance and are intending to record or film any part of today's meeting, please ensure this doesn't disturb the rest of the meeting. So, we'll go on to the agenda. So, have we got any apologies for absence?
Sean Gibbons, Councillor Sean Gibbons.
Okay. And then I don't think we need to consider the extent to which the public and press are to be excluded, because we haven't got any. So are there any declarations of interest? Okay. So we won't be having any public statements because we haven't got any members of the public. So we can go straight into the Health Protection Annual Report. So that's pages 1 to 34 in your information, which I'm hoping everybody's read and is absolutely clear about. So we've got Victor with us. Have we got Rio Overton Bullard?
Rio will join us shortly. I've got the other colleagues with us here.
Okay. Yeah. Would you like to introduce yourselves then?
Thank you. Good afternoon, everybody. Victor Joseph, consultant in public health, Doncaster Council.
Yeah, good afternoon. I'm Cathy Wakefield. I'm Principal Screening Immunisation Manager with NHS England Public Health Commissioning Team.
Hi, I'm Min Boyack. I'm DBTHI, Infection Prevention and Control Lead Nurse.
Hi, I'm Ramona Shafiq. I'm a Public Health Degree Apprentice at Doncaster Council.
I'm Glynis Smith. I'm the chair of this committee.
Caroline Martin, Senior Governance Officer, supporting this meeting today.
Councillor Julie Grace, Roman Ridge Ward.
Councillor Laura Bluff, Bessica Ward.
Councillor Sue Knowles, Armthorpe Ward.
Councillor Yetunde Lebuibon, Whitley, Intake and Clay Lane.
Councillor Linda Curran, Hatfield Ward.
Rio's just walked in. please.
Hi, apologies, I'm late. Rio Overton Bullard, Public Health Improvement Officer at Doncaster Council.
Thank you for that. So there won't be a presentation. Yes. So we're going to go straight into the questions. And I would like to just say before the questions that whilst we appreciate the very long glossary of acronyms and abbreviations, speaking as an individual who has used some of them in a very long NHS career, it actually makes our role very time-consuming to be constantly cross-referencing. And I'm kind of very conscious that, you know, for people who haven't got the background that some of us have, this is quite a complex and difficult report to scrutinise. So it you know, it does make it quite difficult for us. Okay.
Thank you. Again, thank you because we have been coming here to report to you every year. Comments taken, so we'll try to work to ensure that the future report is as clear as possible with minimum acronym. I do understand in various disciplines, people have got their acronym. They do get on the way. So we'll work to ensure that we minimize the acronym as much as possible for future report. If I can give an overview regarding, we're not making presentation, but I thought I'd give you just a quick overview about the health protection situation, how the background, and the context. This is about 10 years now since public health moved from the NHS to the local authority. We have been presenting report on the scrutiny to the scrutiny panel on health protection assurance situation in Doncaster. When we first moved to the council, one of the key things was to define what health protection entails. So some of the lists you see there is a kind of consensus among the public health system in South Yorkshire. We came together and agree what should constitute that. So we've used that as a framework over the years, and it served us well to be able to cover a range of the scope of what constitute health protections. The other thing is to say that it is not one system. It is dynamic as well. Over the years, some of the organizations have changed, some have been abolished, so we have to keep up to speed. For example, health protection. What we now have, the UK Health Security Agency, is a new body now. It has its predecessors, Public Health England. Before that, it was Health Protection Agencies, and we have now NHS England as well. Even our local NHS system have changed. It used to be CCG, now it is called ICB, Integrated Care Board. So we adapt to that. Key aspect of all this is relationship, and I think we work very well with partners, and some of them are around the table here to help answer some of the questions you may have. So through our assurance group, Health Protection Assurance Group, we meet quarterly to ensure that we provide the health protection support to the people of Doncaster and protect and improve their health. So that's kind of a quick overview I want to give before we go to our detailed questions. Over to you.
Okay, thank you. So it's my questions first, and Councillor Curran actually has a question after my first one. So three things in the emergency preparedness really kind of jumped off the page. The first one being scabies outbreaks in hotel for asylum seekers. Second was the measles cases, and third was the syphilis outbreak. So in the case of the scabies outbreaks, I worked with scabies many years ago in the 70s in the very large hospitals. And clearly it wasn't uncommon in those days and the treatments were successful. Would we expect this in a care home today or a hotel? And is this ongoing or successfully treated?
So we've been involved from an infection prevention and control perspective. So if I can talk about the hotel first. So they were 2 hotels where we have asylum seekers who were coming from London via France. And we do know that there were issues with scabies there. And then they came to us. It is resolved now. We did have a few cases that were successfully treated, and it seems to be resolved at the minute. We do sometimes get the odd case. They're usually ones that are new to the hotels, coming from down south. So, and then they're treated by the GP. So we have really good partnership working. So we're kind of on it straight away. But in terms of systems and processes within the hotel to prevent spread, they do the best that they can with in the circumstances. So their processes are fine. Unfortunately, a lot of them are coming from France with some issues, and then they are in the hotels mixing, and so it's difficult.
Would you like to ask the second bit, Linda?
I would, thank you very much. As you said, you're doing the process. So how is the process carried out? How frequently is this done to manage the infection or the outbreaks? And how successful has this been? Because from the sounds of it, it is ongoing.
So the cases are treated. That's not to say that there won't be further cases, because they're getting new people coming from down south all along. So usually what happens is there's a GP practice that will notify us if they've seen any of the asylum seekers in the hotel, that they've seen somebody and have diagnosed them. We will then go in and support with any advice that they need. The GP practice will organise treatment for them.
If I can add to that, we do have a plan in place when we do have outbreak. So we activate those plans. As part of that plan, we call the relevant partner agencies. In this situation, we have GPs who are involved, we have UK Health Security Agency involved, and we have our ICB colleagues who are involved. Some of the logistics are very practical. How do we support the residents so that they are treated at the same time? The key aspect of it is really the individuals in the close contact are treated all at the same time, so that there's no reinfection, and that requires logistic to make sure that their clothes are washed, and they've got some other clothes and how to get this. So we work really very hard together to be able to make those happen. There were challenges around medication as well in terms of sourcing the different type of medication that we can use, because we are not treating one person or a household like 2 or 3 people. We're treating here quite a lot of people, sometimes in the region of maybe 100 or so. So you want medication that is simple and you can administer to everybody at the same time. So I think since we had those, we haven't had new cases of scabies. So, but we are keeping an eye on it because, as Mim says, this group of people, there's high turnover, so new people come in. So it may well be that they came with it, and so we have to be cognizant and keep monitoring. But we have got effective system to monitor things. People going in this hotel. There's close coordination working with the people managing the hotel system. So if there's any problem, we can pick it up. In fact, through our new migrant health officer, we have kind of establish a fair in one of these in the hotel. So all various health providers come there to be able to say, well, this is what we do. So all the agents are seen to be working together. Mim might say something a little bit about the care home one. Again, it is sporadic. It is it once in a while. So cases that were there have been dealt with. There are processes in place to make sure that things like hygiene and so forth are up to speed, so that in the first instant the focus is the prevention. And also, if they do occur, to detect it early and to manage it. I don't know whether you want to say something a bit more.
Just to say that we are very involved with the care homes as a team. My team, we'll go in and offer support there, but we go in with visible, so we go in at least every 4 to 6 weeks in all the care homes in Doncaster Borough that we cover. So giving them education on outbreak management, on scabies, things that they might see. But the care home, we haven't seen any cases in there for a long, long time, and we didn't see any before then, so that was unexpected, really. We don't often see that.
Thank you. From what I understand, scabies is quite infectious and can pass through communities. Have we found this going out into the wider public, or is it contained within the care homes and the hotels?
From my perspective, we haven't seen scabies spread. You need quite close contact for scabies to spread. So you're talking about 20 minutes of skin-to-skin contact for it to spread. We haven't seen any that I know. I mean, Victor might say something else for areas that we don't cover, but it hasn't been a problem.
Yeah, that's right. It is because it's skin-to-skin contact. Really, the focus is about where we detect any case to enforce hygiene measures in those settings, individuals in those settings. And they tend to work well when people maintain hygiene level, avoid close contact.
Thank you, Chair. What definition are you using to class an outbreak? How many cases over what period of time are we using for that term?
The technical definition is 2 or more cases that are linked in terms of either a setting, could be in a care home, for example, but it also could be over time as well. So you may find that you've got one case now. If after 2 weeks you've got another one, there's a kind of time limit, depending on what type of outbreak it is. So there is a time element of it. There is a place element of it as well. The idea is there is some kind of linkage, and then you can class them as an outbreak.
Okay. So my second part of that question. Sorry, Jim.
Right. Just so I've got a little bit more clarity, how long is the treatment plan? How long does it, take from first discovering it to where you think that it's all settled?
Treatment, it's after 24 hours. If for scabies, a normal scabies case, after they've been treated 24 hours, you wouldn't class them as infective anymore, but sometimes they need 2 doses, 1 a week apart. But the incubation period is roughly about 6 weeks from when exposure could have occurred to symptoms showing, because it's the allergic reaction to the mite that causes the itching and stuff. So the mite might have been there for 6 weeks, but you won't pick it up until you get that allergic reaction.
So the incubation period that Mim referred to is when you get the infection before you develop the symptoms.
Okay. So my second part of that question is, I realise that some of our communities might have what we could call vaccination fatigue currently. but I have some very strong memories of working with children who became disabled because of not having vaccinations in the past. So what positive steps are being taken to encourage parents about the absolute importance of the current vaccination programme? And we remain below the efficiency standard for childhood vaccinations. Will that improve this year, and how, really?
Thank you. Yes, so just to kind of pick up on the measles specifically and the MMR, because that's kind of the hot topic at the moment. So as you will probably be aware, there is a national measles incident. There are large outbreaks in London, North West and Midlands. We've had a cluster of cases across South Yorkshire and in Doncaster. But so far, from that point of view, not to the extent that other areas in the country have had. I think in terms of childhood vaccinations generally, we are below the efficiency standard, particularly for MMR, and also preschool booster, which is the diphtheria, tetanus, pertussis and polio. But I think it's worth noting that we are still in line with or slightly above the England average. So we are below the efficiency standard, but it's not as bad as it is in some areas, which I think is why we're so far not seeing the level of outbreaks that other parts of the country have had, where rates are significantly low. Having said that, there is variation between our primary care networks and variation between our practices. So with as a Doncaster system, with local authority colleagues, ICB colleagues and wider partners, we are trying to work with those practices to understand what the reasons for that are. As you say, Chair, some of it is what we would term vaccine fatigue, some of it's vaccine hesitancy. So some of the work is understanding what that means. Is it complacency because we historically haven't seen these childhood infections, and therefore it's kind of a, well, why do I need to get my child vaccinated? Clearly the incidents that are in the press around the number of cases will hope to change those attitudes, and people will realise that actually these infections are still around, they are serious, and that will prompt some of that. Some of it is convenience, and again we're working with all of our providers to look at what that means in terms of access to appointments, making sure that parents can book appointments easily and at a time that's convenient to them. And a lot of the practices have moved over to an online booking system so that they're not sitting on the phone for a long period of time trying to get through to make the appointment. Again, with partners, we're also working with practices, particularly where they've got not high numbers, but more numbers than we would want of unvaccinated children. Again, to look at what the reasons for that are in terms of is it language, is it understanding vaccination, is it I mean, yeah, with MMR, we're all aware of the historic autism concerns, but with some communities, it's nothing to do with the kind of the Andrew Wakefield, no relation by the way, autism scare. It's other cultural issues, and it's understanding what those are. And again, it's working with partners to get those messages across. So we're looking at how we work with voluntary sector community champions, people that are recognised and understood and trusted within those communities, to get those messages over, making sure that they've got materials in a resource that they can understand, whether that be pictorial or translated. So lots of initiatives around that. But we are targeting practices where, particularly around MMR, where there's 0 doses by 15, 18 months of age, so that we've got time to catch those children up as quickly as possible. And again, generally the numbers per practice are quite low in the majority of cases. The other thing that we're doing is working alongside Child Health Information Services with practices to look at where we've got waiting lists for 1 year immunisations and preschool immunisations to again make sure that we can address those and make sure that parents have got access. We're also working with school immunisation providers, again, around how they can support catch-up of all children, and again, looking at kind of identifying where there's incomplete immunisation at entry to preschool, transitions from primary school to secondary school, and when they leave school at the age of 16, so that can be passed back to the GP. So we're kind of working not just on the childhood element of it, we're working right across the kind of the 0 to 16 kind of age band. Rates are stable, which is good, because nationally there's been a significant decline of all of the childhood IMS and the adolescent IMS over recent years. So the fact that it's stable, I think, is positive. So we've not got a downward trend, but clearly we want to see an upward trend. And yes, hopefully the work that we're doing as a system with all of our partners will contribute to that. We're also working with early years providers and family hubs, again, to raise that awareness, get the messaging out there, and also support professionals that are delivering any kind of service to communities to have confident conversations around vaccines, so understanding what the schedule is, what the benefits are, what the consequence of not being vaccinated is, and just being confident in having those conversations in a supportive way rather than a kind of a dictatorial way.
If I can add to what Kathy's mentioned. So in December, we had an exercise, simulation exercise of measles. And again, it was multi-agency to kind of simulate situation where we got cases and what we're going to do. Actually, the issue about vaccination and how we increase vaccination uptake is central to our initiative of prevention. And as a result of that, we set up vaccination cell. It's the one Kathy was talking about. So it is still ongoing, and we think that's still crucial. The vaccination cells brings all the information together, including data by practices. So we have got good understanding by practice how many patients haven't had vaccination or are missing bits of it. So we are going to use that. We're using that information to share with practice to verify that those numbers are correct, because we pulled that from our national system. The point is, few number of cases, even if each practice were to kind of vaccinate 3, 4, 5 additional one, altogether they add up, they improve our vaccination uptake. And that's what we are trying to do. I did some bit of work several years ago, 5, 6 years ago. We looked after children, because it's one of the groups that had got low vaccination uptake. And we use the similar approach, working together with the looked after children specialist nurses, the children team in the council, to pull together a list of the children and to see who has been vaccinated and not, or not. And we were able to go through each one of them and get a good explanation why somebody hasn't been vaccinated. So through that process, we were able to improve vaccination uptake from somewhere around within the 70% to over 95%. So I think that kind of success illustrates that this can be done. We are asking, we've just looked through the highest practices that has got nobody or no child in the age bracket vaccinated, about 20 something. But some of them were up to speed. Some of them have got single figure patients. So we are asking really practice to look at it, that make that extra effort. And if there are bound to be exceptional reason why some of those could not be vaccinated. For example, we know that some children might have moved away, but they are in the system, but in practical terms, they can't be contacted. So those are the kind of things we can do.
Thanks, Peter. Yeah, just to on the children that have moved away, that are still on the system, they may be deducted from the GP list, but they're still on the child health information system, and they cannot be removed from that system from a safeguarding point of view until the child health service receives notification that they've moved somewhere else. So from that point of view, they will always be in that denominator. So that's kind of a caveat to all of the data. I think in terms of initiatives that practices are doing, some practices, particularly where they've got longer waiting lists, are looking at putting on additional clinics after at the end of the school day, for example, particularly where they are close to the school, because parents are already going into that area. They're already parked up if they're driving. They're already picking the children up. They've generally got siblings with them. So those kind of things. So it seemed to be an ideal opportunity if they can put an extra clinic on kind of 3 till 5 or something to get those children in. Some of them are also working as a primary care network and working collaboratively so that, again, they can kind of broaden the access to the children that they cover. So they could go into a number of practices rather than just the one that they're actually registered with. So that's in its early stages, but that's something that we're looking to develop how we can do that within the constraints that we've got around kind of vaccine supply, movement, those contracts, those kind of things. But collaboration is definitely the key. And the school IMS provider, again, over Easter, they're utilising the health bus to target children in schools where we know that we've got low uptake, and also kind of general catch-up for, again, children up to school leaving age. So a lot of initiatives that are going on.
Thank you for that. Are there any further questions? So my third bit of the preparedness was really around the syphilis outbreak. And in the report, it says that the rise has continued. So has the recruitment, support and measures introduced made any difference, like the new public health improvement officer, specifically to address those issues?
So first is to kind of say, yes, we have capacity in the system. The purpose of having this capacity is to be able to detect cases early and to be able to manage them. Without a system to be able to identify those cases, we would have cases in the community which we wouldn't be able to pick up, and as well as the management, because the issues around how you go about the contact tracing to be able to follow those up, they are key. So we do need a system to be able to track those cases. Yes, our workforce capacity has helped in terms of raising public awareness. So we've done quite a lot of work with our GPs, with our dentists, with the hospital doctors as well. So the issue is about raising their awareness so that when they see a patient with potential signs and symptoms, they think about it, because these are rare diseases. So an average doctor may not see them for a very long time. So it's important to alert them. So we've done joint letters with sexual health clinics to raise awareness on this. So it is a collaborative approach. The providers, us in public health and the other partners, all working together. It does contribute to the capacity we've got in the system is ensuring that we have a resilient and effective system that can be able to respond to this. Again, behind the scene, what you have not probably seen is the moment we identify, you asked the question about what constitutes outbreak. We've got 3 or 4 cases. We convene outbreak control meeting. We put all relevant agencies together, to understand the profile of those cases, the linkages, where they point to, and that kind of help us in formulating our actions. And we have, through our contract process, to monitor how the services our sexual health services is being delivered. Obviously, working with other sectors, the voluntary sectors as well, because some of the client groups, they are engaged with some of the local system, local support, voluntary support, charitable work going on in Doncaster where they get support in. So the services are linked to those providers. So we through this outbreak control meeting, we formulate sets of actions and monitor them. Again, through our contract system, the service specification which outline what needs to be done. So this is why we have dedicated officer to be able to ensure that our public health commission services are delivered and supported accordingly.
Thank you. I don't think we've got any further questions on that one. So the next question is from Councillor Knowles.
It's about the naloxone kits. How widespread is the training, and do you have any figures on training or the numbers of successful administration using the kit?
We managed to obtain some figures regarding the kits. We have got about 143 in the last 4 months that has been given out. In terms of how widespread it is in terms of the training, we've got a range of partner agencies that have staff trained in them. For example, the Complex Lives team, staff in Complex Lives, Riverside, the one deals with homeless, and then the service linked to children aged 5 to 19 services, the hospital liaison team, Project 6, the street pastors, the probation services, the Methodist Church, and then patient focus group. Again, this is the group that support people with learning disability, rough sleepers. So the high range of group of people where training has been given. The challenge they've got is trying to collate the number trained in those group. But Aspire, that is holding the service, they do have a good system in terms of recording the training they have given to their staff. In fact, they have got very good programs in place in terms of how to take this forward as far as training is concerned. So they make the training mandatory for staff, and they intend to provide sessions once every 2 weeks. Each session about 15 people. So I think going forward, hopefully they will have a system to be able to collate those figures, and we can be able to get a bit more detail over time, how many they have trained.
Yes, thank you for that. There's a second part to the question. Do you have numbers for the numbers of successful administrations using the kit? In other words, how many times has the kit been used and successfully?
They haven't got that. They haven't forwarded that information to us. But obviously, what partly maybe the challenge of how to track the usage among the other agencies that they have trained in the usage. What they were able to kind of say is the number through the internal system. Aspire, once they've done it, they kind of log it as part of the incident report. So they have a very good recording system, but we can get that detail in terms of the successful outcome.
Thank you.
Okay. So the next question is actually mine, and that's about the avoidable repeats in the newborn blood spot. The test isn't new. I've certainly been aware of it for a very, very, very long time, and I clearly remember it, although it was being used for very much fewer conditions, very much fewer screenings. So if this screening's requiring a repeat test, can we have some reassurance this is always flagged and retested? Because I'm very aware with family members that a stay on the maternity ward nowadays can be hours, not necessarily even days. And would the fact that it hadn't been done or that it required repeating, be flagged to primary care?
Yeah, thank you, Chair. So, firstly, just to say that newborn blood spot is a key performance indicator for maternity providers, so it is continually monitored. It is the responsibility, and it remains the responsibility of the maternity provider, so it doesn't get handed over to primary care GP at any point. In answer to the question, yes, the samples are monitored and they are flagged to the antenatal and newborn screening coordinator within the maternity provider where repeats are required. And repeats could be required for a variety of reasons. One is that the form doesn't get squashed when it gets posted. That can impact because it's a tiny dot and the machine has to kind of press through it. So if that gets squished in any way, then it does affect the quality of the samples. So that's one reason. The other key reason is incomplete samples. So there's 3 dots on the card, which some people may remember as being the Guthrie test. So there's 3 spots and they have to drop a blood onto each of those spots. So if there is insufficient blood, then that would prompt a repeat. So yes, wherever a repeat is required, then that is flagged as I said, to the antenatal and newborn screening provider. If the repeat isn't done by the time the baby is discharged from the maternity unit, then the antenatal and screening newborn provider will liaise with the community midwifery team. So the sample is taken by the community midwifery team. Occasionally it may be done by health visiting team, but generally it stays within the maternity provider as the responsibility for that service. The antenatal and newborn screening provider has put a number of actions in place to try and address this. And again, it's kind of been formed part of a wider South Yorkshire kind of newborn blood spot task and finish group to try and improve the standard of sample taking. So one of the challenges is the turnaround of midwives, particularly where they rotate between community and hospital. That can have quite an impact. So they've enhanced the training that they provide to midwives, both on rotation and new midwives, again to try and make sure that they understand not only the procedure but why they need the size of sample that they do, and they're also auditing that on a regular basis as well. So again, if there was a midwife, either community or hospital, where they were kind of regularly flagging as their samples needing to be repeated, then there's a targeted action plan with that individual and targeted training with that individual to improve their technique, really, because usually it is down to technique. So yes, it's closely monitored by ourselves as commissioners of that service, but also within the maternity service.
So our next question is from Councillor Ellerbaum.
Thank you, Chair. So my first question is regarding the infection, hospital-acquired infection. And under the plan and review section, there was a statement here about gastrointestinal outbreak unfolding at a local event during a heat wave. Just curious about what gastrointestinal outbreak this was.
I can answer that one. It was a staphylococcal infection that we decided to go for. So that's food poisoning caused by Staphylococcus aureus, simply because it's quite a common cause of food poisoning, especially linked to sort of improperly cooked food available through fast food vendors. So it felt suitable given that it was a festival scenario that we were simulating.
Thank you very much. And I would say because of the incubation period as well, will be suitable, you'll be able to get a good result around that time.
Exactly, yeah, it's very short, minimum 30 minutes. So we thought that, you know, people could develop symptoms plausibly whilst they were still at the event. Yeah.
So just to add to what Rios mentioned there, this simulation exercise is really very useful for us because it gives us an insight into public health challenges and also key preventive messages that we need to pass through. And broadly speaking, they are common sense public health thing, could be a broader hygiene measures that need to be in place, ensuring that we cook our food properly, well. So it's just kind of reinforcing those messages. So there are simple action that could be done and will avoid illness and death. So I think that's really the purpose of why these simulation exercises are really important.
Yes, thank you very much, Victor. Another aspect to it, because I see that you mentioned proper cooking of food. Because of the nature of the organism, Staphylococcus aureus, and the fact that it stays on the skin of people, it's not only during food cooking, but food handling, and the way food is kept as well. Because after cooking properly, if it's not handled well, you don't need to do much to get staff because they're there, they are normal resident on the skin. You don't need to do much to get them into food. So it's all about the handling as well and how they are kept and, you know, who's got access to what. So, but that's a very good organism of choice for that exercise. Thank you very much. So, Chair, is it okay for me to go to the next question? So the next question is also about the healthcare-associated infection. And there's a report here about the low cases, as low as 0 cases of MRSA, which is methicillin-resistant Staph aureus, bacteremia. And I had to explain to my colleagues what bacteremia means, which is blood poisoning, when you get pathogen microorganisms in your blood that could cause a serious infection. Also, methicillin-sensitive Staph aureus, bacteremia, gram-negative bacteremia, Clostridium difficile infection as well. I would just like to know for which period of time this result that was reported was given. You know, judging by the fact that these are, you know, bugs, these are big players when it comes to nosocomial infection, hospital-acquired infection, and you rarely get to a stage whereby for a long period of time you're getting 0 cases. It might be very, very low, but it's difficult to. So I want to know, you know, what period of time what screening policy was used. Because when I used to work in the hospital, we used to screen ICU patients, and that is intensive care unit patient. Screen every inpatient, everybody coming for surgical procedure, so that we can ascertain where the infection actually comes from. So if you are clean from your community to the hospital, we know that if after treatment or surgery you develop the infection, it must have been picked up within the hospital at that point. So if you don't mind explaining to me,
I'll start off. Maybe I'll bring Mim later. So the section of the report you referenced there relates to others. It related the period Q1 and Q3, which is April 2023 to December 2023. So I suppose the trajectory is really to have no MRSA, but obviously we do get situation where we do have a case where that happens, because it's really important, it's a key indicator. It is looked at to identify what the root causes are. So got a multidisciplinary team together to look into those cases, and DBTH has got a separate section of the report, and I think you may touch on it as well, where we had some cases. So this related to different hospitals. So as part of our health protection assurance report, we do get reports from both DBTH and also others on that. In terms of how do we get it to 0 cases in terms of screening policy, again, we might expand on that. But the key thing is we have national policies in place. Those policies are translated locally so that they are implemented in each setting. So in the hospital, as well as in settings such as care homes, there are sets of training going on as key part of ensuring that staff that are involved, they are trained, they know what to do. That's the whole point about prevention. And there are measures around monitoring and audit going on to ensure that what needs to be done is being done. So before even we get any cases, so we check that the system, the procedures are working well. Where there are breaches, the support available through the IPC teams. And I'll pass over to Mim, who will probably expand further on that.
Yes, so as Victor says, RDASH is a mental health organisation with some physical health wards, so their infections do tend to be lower than our acute organisation. But in terms of finding MRSA, we do screen, in accordance with, like Victor says, the national guidance. So we'll screen anybody who's admitted, apart from such as people having day surgery, dental procedures or eye surgery. But we screen everybody on admission. We also have screening protocols. So if the patient's in more than 30 days, we will screen them again monthly. So we're actively looking for it, basically. And then when we find it, we can give treatments to decolonise. And that's what we do. But we also do all the education around, how to prevent, all the PPE standard precautions and all that kind of things as well, just to minimise that. You cannot eliminate the risk completely because people carry it on their skin. So it's a challenge, but we at DBTH, we have gone a lengthy period without, so over 700 days, and then we have had some cases. And a lot of them were linked to MRSA PVL cases in the community. So in section of the population that are intravenous drug users, we were picking cases up when they came into hospital, which led to a kind of joined up approach between UKHSA and our local partners to see what we could do to support and view it as a whole, as a whole system. So we at DBTH came and worked with Changing Lives. We did a drop-in session for those people where we tried to explain what MRSA was and the implications of having MRSA and how poorly it could make them if they did get a bloodstream infection. We gave them decolonisation therapy. We did what we could, and that continues. And we also, on our electronic systems, if we know somebody has got known to have MRSA in the past, that will flag on our system. So when they come back into hospital, we can be on it straight away. We can do the isolate them and give them the decolonisation therapy. But we do even more screening in terms of if they've got invasive devices, so if they've got a urinary catheter, if they've got a line-in, then we will screen them weekly. So it's really the principle is actively looking for it, and then when we find it, jumping on it quickly.
Maybe if you can explain it, if you can explain a bit more about decolonisation.
Oh, sorry, decolonisation. So we give Prontoderm foam, which is you put it on like a moisturiser. So it's a foam bottle, and you put it on all over your skin, and it suppresses the microorganisms because we're covered in bacteria. So, and like I said, some people carry MRSA and MSSA, so it suppresses that. So we keep that, try and keep that at low level, or get rid of it actually as well. And we give mupirocin nasal ointment, which is like an antibiotic or antimicrobial ointment up the nose, because that's where you carry MRSA as well. Just there.
Thank you very much, Mim. Before I move on to the next question, because I was about to ask about the colonization before Victor asked the question, you mentioned PVL cases, and for those that doesn't know about PVL, it's panthovalentine leukocidin. It's a toxin that is produced by Staphylococcus aureus, and it's a serious one. So while you were talking about colonization and the decolonization of the skin, when you have cases of PVL and Staph aureus, what are the extra steps you take with the patient and also maybe families or those who have had contact with?
So PVL, we treat it very much the same like MRSA, the non-PVL strain. In terms of decolonisation, we will do that. But certainly we have a standard operating procedure in our organisation that was developed on because of the extra, the PVL cases. And we will make sure that we're treating with anti-MRSA antibiotics earlier. So we've got a low threshold for doing that. In terms of, you do find PVL more in communities rather than in hospital. I'll pass over to Victor for what happens with... GPs will decolonise as well.
So what is the space of you retesting? So what's the space of retesting after you decolonize?
So we will decolonise for 5 days, and then we will leave 2 days, and then we will screen again. We do screen, GPs will also manage patients with decolonisation therapy, but it's trickier when you're in the community because it might be that that's their normal bacteria for them, they carry it. So you often find that we may decolonise them when they come into hospital, but when they go back out, they pick it up again. That's the reason why we look for it each time they come into hospital. So if they've been previous, we flag it on our system, we pick them up straight away and decolonise them again because they can recolonise.
Thank you. So I have 2 more questions with that. I'm just going to wrap them in together. So this is about testing for other healthcare-associated infections like vancomycin resistant, enterococci, VRE, strep pyogenes, which are not mentioned in the report. So if you already test for that, it's just a matter of you saying that, yeah, it wasn't just written that they've been included. Also, you talk about continue to maintain low level of healthcare-associated infection. You mentioned some of the steps, which is in case of MRSA, but because it's not the only healthcare-associated infection, if you just brush up a little bit on what steps you're taking to maintain this low level. Thank you very much.
The low level of is referring to R-dash. So, I'm from DBTH, but the steps are similar in we screen. So if you're talking about VRE, there's a guidance for CPE screening, which is a swab that will pick up VRE because that's what we test for. So
and CPE is carbapenemase.
Carbapenemase producing enterobacter.
Enterobacter C. So,
and carbapenem.
Just to make people understand what you're talking about.
Carbapenems are a group of antibiotics. So this enterobacter will carry resistance genes that make those antibiotics worthless or not effective. So there are screening strategies for that. In terms of other things like C. diff, we will test when they're symptomatic. We will also flag them like we do for MRSA patients so that we can watch when they come in. But in terms of preventing spread, that's all through basic infection prevention and control, standard precautions, hand hygiene, wearing PPE at appropriate times, dependent on what the organism is that you're dealing with and how that spreads. Is that what you were asking? Yeah.
Thank you. Can I go on, Chair? Okay, thank you. So using the catheter passport to improve urinary catheter care to assist in the reduction of gram-negative bloodstream infection. I'm wondering if this is a typo issue, because when I read gram-negative bloodstream infection, that doesn't make sense to me, because gram-negative is a stain reaction of microorganisms. It could be bacteria, it could be coliform, it could be different type of bacteria. So that's why I'm asking that, is this referring to GMBs, gram-negative bacilli or coliform? Is it referring to gram-negative cocci? Because there are different procedures or different outcome for different organisms. So can you please provide a bit of clarity on this?
So gram-negative bloodstream infections are a group of gram-negative bacteria, like you say, and the catheter one is relating really to E. coli. So E. coli is a bacteria, gram-negative bacteria, that can be colonized in the.
Yeah, I think that's what's missing from it, because it says gram-negative blood. It didn't say gram-negative bacilli or coliform, or I don't know if you've actually picked it up from the report.
Well, we have other gram-negative things that we deal with as well, so that we have key performance that we report against. So E. coli is the one that we're trying to tackle with the catheter passport, but there are others, that wouldn't be associated potentially with the catheter. Is that okay? Does that answer your question? No.
Not really, but I get what you're saying. I think my question is not clear, because what you explain is UTI, urinary tract infection, are usually associated with, mostly, not all the time, are usually associated with gram-negative coliforms. That's what you see most of the time, but you do see other organisms as well. But what I'm saying is that from this report, it didn't mention coliforms, it didn't mention coccus, it just mentioned gram-negative blood stream infection. And I know it could be linked to catheter and UTI, but that it wasn't just clear. To a layman person who doesn't have a medical background, it just might not mean anything, if you know what I mean. Sorry. Thank you.
Maybe just, if I can, for the benefit of the wider audience. So the catheter passport is really to help ensure that there's systems in place where patient can be tracked, because when catheters is put in place, you get infection, different type of infection. So the detail that you're talking about, basically the different type of infection, which can make situation worse if there's no proper record of the catheter, when it is fixed, and when it's expected to be rechecked, and all that kind of thing. So it gives assurance, quality assurance, that it is being monitored in ensuring that patient remain in good state. So this is really what it is about, a system to ensure that patients are well looked after and are cared for. The rest are the detail in terms of, yes, different infection could get in and can make a bad situation worse, particularly get into the bloodstream.
And we've got a question from Councillor Greenhall next.
Yes, thank you, Chair. Going on to the suicide statistics for Doncaster in 23, is there any factor affecting the increasing rate of male death linked to suicide? For example, mental health issues, lack of requesting for early intervention, and I would think maybe social media effect. Have you any view? Thank you.
Thank you. Yeah, suicide is definitely a complex interplay of many factors, and there's usually not only one single cause. Nationally, 3/4 of suicides are mainly in males, and 1/4 of them are in females. Locally, we continue to monitor any possible clusters of cases by persons, place, and methods of suicide, but also any changes in rates overall or by gender or age are also being monitored. There are factors such as loneliness, stigma, particularly men who are much less likely to get help for their mental health issues, the use of alcohol, and severity underlying illnesses will all be part of those complex pictures. Men are particularly more likely to use lethal methods of committing suicide. They wouldn't also volunteer this unless asked directly. We have real-time suicide surveillance systems in place, and an active suicide prevention network that is commissioned as a commission service, including bereavement support. There's something we call postvention. This is a package of support provided to support families, friends who are affected by suicide. So that package of support is available. And the rationale behind is people who are bereaved from suicide are more likely to also commit suicide. Several years ago, I used to chair also a steering group of suicide prevention, and this is for every one suicide, you find there are about 30 people who are immediately affected by suicide. So the network support other targeted or community-based approaches to suicide prevention that aim to improve social connections, especially for men. So, yes, to summarize your point, suicide more common in men and less so in female. Men seem to be less forthcoming in terms of articulating their concern. And there is a system in place in Doncaster in terms of suicide prevention group that is looking into what needs to happen, and as well as monitoring the cases we've got in Doncaster.
Yes, thank you for that analysis. I do agree strongly that probably loneliness is one of the main contributing factors with a male. I've seen some adverts going around advertising to seek talk about things and requests for help from certain quarters. But I think personally, I think given the statistics of 84% of deaths by suicide last year were male, it's a terrible disproportion. I think a good advertising campaign wouldn't cost the earth to sort of like illustrate in a simplistic form the factors of loneliness, talk to somebody, it's not the end, blah, blah, blah. Because a friend of mine at school back in the 60s, it was drugs that actually forced him to commit suicide in the newly built Silver Link pub many years ago. And that was a great tragedy for the class because nobody did that then. So I do think, especially with the social media pressures and that, a more vigorous explanation and willingness to come forward and to talk about your personal issues in a private session or something like that, reassurances would have a positive effect. Thank you for your analysis.
Thank you. Oh, yeah, sorry.
What I found in my community with mental health, we're like looking at men and women, and we can put events on for women, but we're finding putting events on for men is far costlier for like pitch hire than what it is if we just do room hire for ladies. And we're just finding that one of the barriers is the cost to putting on these things in the community. So that is something that really could be looked at, because there is a massive financial difference in the things that would interest men, get them together, because we have got a group, but it is draining us resources financially.
Thank you. We'll feed that to our team that is leading on this agenda. So thanks for your comment.
I did the Zero Suicide Alliance training last year, and you know, even as a registered nurse, I actually found the training so beneficial, because I think it's that difficult question that I know some nurses don't always ask. And, you know, just saying to somebody, have you ever thought about ending your life? It's the big elephant in the room, isn't it? It's the one question that we skirt round and we don't ask. So I suppose what I want to know is, does this training continue around Doncaster currently, and will it be continuing? And is the funding still there, really?
Yes is the short answer. So the training is still continuing in a variety of community venues. It's also looking to embed this as part of training, the trainer program. So in a way, the fact that we continue to do this, the limited support funding results we've got will continue to support this training going on.
Thank you. That's really reassuring, Victor. I think our next question's from Councillor Elevon.
Yeah, thank you, Chair. So my last question is about the mental wellbeing micro grants. I'm interested in this. I want to know what criteria is there for the application, how long this has been running for, and if you've noticed any impact, you know, on the grant, the impact of the grant on the community. If you can state this, and or how you wish to measure the impact. Thank you.
Thank you for that question. So the criteria for the grant is first of all, it is to help support residents to improve their mental well-being and promote better mental health and to prevent mental ill health. Number one is it is for not-for-profit voluntary or community organizations, and then faith-based organizations, not-for-profit companies or community interest companies or social enterprises, also food banks as well. How long has this been running? So we've got a pilot in place from December last year. So it's continuing to this financial year. There is a plan to allocate funds for the next financial year as well. Regarding impact of this project, there are 10 successful community groups across the borough that has been given the grant, about £1,000 paid out so far. And then the plan to, regarding measuring the feedback, it's about contacting those who were successful so that they can provide some answers to some key questions. For example, who has this grant help? In total, how many residents did the grant reach? And describing the grant, the people that who have been helped with some case studies with examples. Anything else that we can get from the feedback would be part of that that impact assessment. Obviously, we would aim to get some case studies as part of that, photographs or good news stories. So this is an ongoing piece of work. And you're right, lots of interest. We want to make sure that it has the impact we envisage, and we hope to share that out. This is a pilot, but I think we will build on that. The experience with community initiative is small amount of money can go quite a long way to do quite amazing piece of work, and I think this is one of them. And this is building on experience of similar initiative that the public health team have been engaged in terms of community work, supporting community groups to come up with initiatives. Usually not a lot of money. It may be a little bit more than this one, but I think the outcome has been quite amazing. Sometimes we need to look at the wider or intangible outcomes where groups are coming together. That in itself is a positive sign where people have not been coming together. The fact people come together in itself is a good outcome. And obviously helping to identify and solve problems together is a key aspect. So we wait for the feedback. There's a plan in terms of getting the feedback of the impact. These are short term, but I think we need to look at communities coming together, what the impact is in terms of long term as well. Obviously, we can't measure the long term now, but what we can measure in the short term is what we can be able to use for the grant monitoring. Thank you.
Thank you very much, Victor. I've made some notes from what you said, but I just want to add a little bit to the tracking of the impact, because I was expecting, first of all, from the criteria, something in the line of referrals from organization, referrals from social prescribers, from people who have got access, maybe medical personnel who have got access to people that's got mental well-being issues. And also in tracking the impact, it's also necessary to look at what is working and what is not. So because from what you've explained, 10 organizations have got this fund, and we haven't actually tracked what activities they're doing with the fund, but it's still early days because you said it started December 2023, so we are looking at just 3 months. So in terms of the long term for this pilot to see, if it goes further, it might be better to see what activities that they're delivering so that we can track what is working. So from the feedback that you get, you will be able to test, these are the activities that is working because so number or percentage of people responded positively or got this percentage positive impact or better when they carry out these activities. So we don't just fund things for the sake of it. We know what's working and what's actually having impact in people. Thank you.
That's a good comment. I think feedback as well. We can pass to the team in terms of highlighting those things to be reflected in capturing the impact. Clearly, the activities that each group are doing is important. So thank you for that comment.
So that's the last of our questions. You'll probably be relieved to know. So as a panel, we're asked to really note the achievements, challenges and mitigations and clearly measures across the breadth of health protection for the next year and the priorities and work planned for the last year and the priorities and work planned for the forthcoming year. We've noted the overall assurance on health protection for the people of Doncaster, and we also have noted the acceptance of additional funding for smoking cessation from April 2024, which we all know is very much needed in Doncaster. So it remains for me to say thank you really for coming this afternoon and answering all of our questions. And I'd like to give you the opportunity here because we're actually going to do our work planning next. So if you'd like to leave at this point, you're very welcome to stay, but I appreciate everybody's got full diaries and things to be getting on with. So if you'd like to leave, that's absolutely fine. We won't have a problem with that. Thank you very much.
Thank you, everybody.
Hi, the next final item's just the usual update on the work plan and forward plan. So, as you know, this is the last meeting of this year. Although we do have a regional health meeting with the chair on Monday, and they'll be looking at dentistry, but looking at it with Sheffield and Barnsley and the other people on the committee. And there's another item which I can't remember, but we'll if there's any feedback, we'll come back on that one. So after this, what we'll start doing is work planning. So we'll probably see an email soon coming round asking for any items. But what I'll do is I've noted requests for updates and anything specific from during the year in the meeting. So just to let you know that. The other area is a forward plan. So nothing specifically to come to the panel. It mentions two things though, which just might be of interest: endorsing developments to adult social care, public information, and the frameworks to support further improvements, which may be something you want to look at next year. And secondly, to approve adult social care market position statement. So not something for the panel, but market position often kind of features part of the finance and performance general over picture looked at by OSMC. So I don't think I've got anything else to raise, Chair, unless anybody else has.
Anybody else? No? So this meeting is now closed.